Hello, my name is Carl Viscure. I'm the director of the University of Southampton Auditory Implant Service, and I'm a professorial fellow. So the purpose of today's lecture is to give you some overview about different aspects of medical and surgical sides of cochlear implantation. So I think the first thing to be aware of is that even if you're an audiologist or a therapist, you do need to understand some of the basics of surgery and some of the basic medical issues around cochlear implantation. Because if you don't, you're not going to be fully prepared to treat patients, to rehabilitate them. So I just want to cover a couple of main items, and I want you to be aware that for each of these, there's a lot more out there to learn. So I want to point you in the direction of these different topics. So the first area really is about what we need for successful cochlear implantation and how the medical assessment fits in with that. I would also like to talk a little bit about why imaging is needed and also why meningitis is important in the context of cochlear implantation in particular. And I'd like to say something about surgery briefly and also about complications. So the first thing to remember is what is a cochlear implant? So it differs from a hearing aid in that it requires surgical insertion. So it isn't just an audio processing device, it's also a surgical implant, or if you like, a bioimplant. And it's designed to provide some benefit to people who have a severe, profound hearing loss. It doesn't fully replace their normal hearing, but it does provide access to things like speech perception, identification of sounds in the world around you, and enables you to communicate in a way which you wouldn't be able to do if you didn't have the cochlear implant. So the critical question for somebody deciding if they need a cochlear implant is whether they're getting enough benefit through an acoustic hearing aid. Now, we can define this in different ways, but essentially, if even with a well-fitted, high-powered, high-quality digital hearing aid, for example, you are not able to communicate effectively, you're not able to understand what people are saying, you're not able to interact with the world, then it may be a cochlear implant is the right thing for you. So the point about a cochlear implant is it's a cochlear implant both in the sense that it sits in the cochlea, but also that it bypasses what the cochlea does. So it actually goes past all of the initial stages of the auditory system, the outer and the middle ear, and the cochlea itself to a large extent. Now, the reason it's even possible, or that it even works, is for most people with severe to profound deafness, the reason that they're not able to hear is because the hair cells inside the cochlea are missing or they're not functioning properly. But at the same time, the neural connections which lead up to the brain and enable hearing are functional. If these aren't functional, then a cochlear implant is not going to work. But in most cases, that is the case. And one of the objectives of the assessment for a cochlear implant is to ensure that that nerve or those neural elements are likely to be functioning reasonably well. Otherwise, a cochlear implant won't work. So the cochlear implant produces direct electrical stimulation and allows the hearing nerve to respond and to stimulate the parts of the brain which would normally receive a signal from the normal ear or the normal hearing mechanism. And that's why this technology is generally very effective. So I think it's worth just thinking in the context of how we assess and how we treat cochlear implant candidates and decide who needs a cochlear implant. What do we need to have in place? What do we need to know to ensure that they're likely to be a successful cochlear implant user, and therefore we should go ahead and provide surgery? So one of the things is we need to have a cochlear structure which is reasonably well formed and can support a cochlear implant. And one of the objectives of assessment is to ensure that this is the case. We also, as noted before, need to know that the hearing nerve is going to function reasonably well. So it needs to be present, there needs to be some sort of auditory nerve, and ideally we would like some idea of whether it's likely to support the sort of hearing process that normally occurs. Ideally, we'd also like to know that there are enough nerve cells to transmit the signal, although that is in fact quite difficult to assess, and we're probably still at a point where we're not quite sure how to do that. But it does form one of the questions we have to ask ourselves if we think somebody is potentially a candidate for a cochlear implant. We also need to know if the central nervous system, the person's brain, is able to respond and understand and actually process the sound. That's not always possible to do that, but we need to have some estimate of that. We need to some prediction of whether somebody is able to then perceive and successfully process the sound. And then the final component is that the person has to be able to undergo surgery. Normally this is with general anesthetic, although it occasionally could be with local anesthetic, so they need to be fit and well enough to cope with the surgery and to cope with the anesthetic. So what all this means is when we're assessing somebody who might need a cochlear implant, we've got to consider various things, and we need to determine various answers to various questions. So one is the person needs to be an acceptable anesthesia risk. So I'll say a little bit more about that in a second. So cardiac issues, respiratory issues can be problematic if we want to get the person to undergo general anesthetic. As noted, we need to know that the auditory nerve is present. And we also need to know that there's no active middle ear disease or middle ear infection, because if there is, this will cause some risks, including an increased risk of meningitis. It may cause other complications, and we don't want this to be the case. So we need to know the situation here. We'd also like to know what the cause of the hearing loss is. Now, that doesn't mean that there is a particular cause of hearing loss that absolutely precludes the use of a cochlear implant. However, there are some causes where there's something called ossification or bony growth. There are some causes of hearing loss associated with structural abnormalities of the cochlea, and these may not mean it's impossible to provide a cochlear implant, but they do mean you need to think about it, you need to know about it, you may need a different type of implant, you may need a different surgical approach. So we absolutely need to know about these things. We'd also like to know about psychological factors to ensure the person's able to accept the cochlear implant when they receive it. And the other medical issue, and ultimately it is the responsibility usually of the surgeon or the medical team member, is to ensure that the person can give informed consent, that they know what they're undergoing or their parents know what they're undergoing, and they can consent to the surgery. So just thinking in a little bit more detail about what the more medical aspects of the assessment are, I think the two main components are, first of all, that the person needs to undergo imaging to have a look at the cochlear structures. And they also need to go on some sort of anesthetic or surgical consultation to make sure that they're fit and well enough and able to undergo the surgery. Without this, there's too great a risk of going ahead. In terms of the anesthetic, there's some general considerations. So obesity, for example, can be a risk factor to undergoing general anesthetic. And people who are very old can be at greater risk to have complications with anesthetic. Additionally, we need to know the person's size to titrate the appropriate dose of anesthetic. And in rare cases, but in some countries more than others, local anesthetic is also possible as well as general anesthetic. So we have, for example, cases where very elderly people have actually undergone cochlear implantation with local anesthetic. There are probably a few other considerations. So, for example, if a child is known to have a particular type of syndrome, then that syndrome might bring with it some risks in terms of the medical scenario, in terms of their fitness for surgery. So, for example, Treacher-Collins syndrome might make the medic or the surgeon think more about the need to manage the airway. There are increased risks of airway obstruction during surgery itself. Or another example would be, Jervell and Lang-Nielsen syndrome, where there are cardiac issues, and we need to know about these in advance as well. So a key part of being assessed for a cochlear implant is ensuring that you're medically fit and that the risks are known so that the anaesthetist can deal with those risks and can change the procedure if needed. So I just want to introduce one other topic briefly, which is meningitis. Now, meningitis is a disease which causes a lot of complications. Deafness is just one of those, and there are a number of other issues that meningitis causes. One of the things about cochlear implantation is it does also introduce a small but increased risk of meningitis. So if somebody undergoes cochlear implant surgery, it's absolutely essential that they receive antibiotics preventively in order to reduce this risk. It's not a very heightened risk, but it is known to be associated with cochlear implantation, and that's because of the connection between the cochlea itself and some of the meninges, as they're called, the spaces around the brain. But the second side to meningitis and cochlear implantation is if you have been deafened with meningitis, there is a very big risk that there will be bone formation in your inner ear, in your cochlea, and this is referred to as ossification. So what happens is that soft tissue gradually turns to bone, and this can occur very rapidly, in some cases within a matter of weeks. So in terms of assessing somebody for a cochlear implant, it's absolutely essential that you speed up the assessment process, that you get them as early as you can, because if they end up with an ossified cochlea in which bone has formed throughout the inner ear, you're going to have more difficulty with the with the surgical insertion and also with the treatment afterwards. So I'll just say a little bit more about the imaging process. So normally, cochlear implant candidates undergo both MRI or magnetic resonance imaging and computerized tomography or CT scanning. So these two forms of imaging tests give us slightly different bits of information, and they're complementary. And it's generally preferred, at least in some countries, to undertake both of these forms of imaging for people who might undergo cochlear implant surgery. So MRI is particularly good at looking at soft tissue, although it will tell us something about bone formation as well. It will tell us something about cochlear abnormalities, although CT scanning may give us more information there. And also it may give us some indirect evidence about the risk that the auditory nerve is not present, usually because the canal inside the inner ear space is very small. So this is a crucial part of the medical assessment for implantation. The other side of it is the CT scan, or computerized tomography. And this is really helpful for the surgeon, actually not just whether somebody should get a cochlear implant, but also how they will orientate themselves as they approach the surgery. So the actual shape of the structures around the cochlea and the orientation can give us a lot of information before the person goes for surgery. And it will also give us some ideas of diseases or abnormalities of the bony labyrinth. The ideal form of CT is called cone beam CT, although there are other forms of CT scan that can be used. So what does it all mean? We've got the test results. We don't want to do tests for the sake of it. We want to know that the result of the test tells us something useful about whether this person needs a cochlear implant. So it can give us different types of information. So one type of information is we might need to change the type of electrode we put inside the cochlea. For example, if we have bone growth in the cochlea, then we actually may need a special type of electrode that is straighter and firmer and actually will go more easily when there's resistance during the operation process. We might need to modify the surgical approach, and we might also need to give the person undergoing the surgery or their parents an idea about expectations that these might need to be modified. We might encounter difficulties more readily because of these sorts of findings. And in some rare cases, it may preclude cochlear implantation completely. So if we think there's an absent auditory nerve, then really there's no point going ahead with cochlear implantation because it won't do anything, it won't help the person. So I want to say a little bit about the surgery itself. I'm not a surgeon myself, I'm an audiologist. I would advise, if you're interested, there are many videos available via YouTube and other sources to look at the surgical process, or if you get the opportunity to sit in a surgery, it's really worth doing. Just a few pointers though to give you some idea. The operation is required to insert two main components. The main component called the package or the receiver stimulator has to be placed inside the mastoid bone. And then the second part, which is the array of electrodes which stimulates the inner ear, needs to be put firmly inside the inner ear and needs to be able to sit there. So the receiver stimulator is housed within the mastoid bone, and it includes the magnet, and then the actual electrode array sits inside the cochlea. So in order to insert the receiver stimulator, or the package as we call it, an incision is usually made above the ear, usually fairly small these days, around there, and flaps are created and two pockets are created. One of these pockets will actually be shaped so that the implant package can sit inside it within the mastoid bone. And this part of the operation actually typically takes quite a long time because there's a lot of bone removal, there's a lot of shaping of the mastoid bone to enable it to take up the implant package. And if you sit in on an operation, quite a lot of it is essentially the preparation for this first part. Then inserting the electrode array itself is quite a delicate operation. It needs to be inserted into a chamber within the inner ear called the scala tympani, or ideally it will be. And it can be inserted directly into a structure called the round window, or in some cases, the surgeon may make a small hole just to the side of the round window, which is referred to as cochleostomy. And either technique gives very similar results. And there is an additional electrode which sits outside the mastoid bone for one or two of the devices. And this is a nice graphic just to show you kind of where the electrode array should sit. And that's within that compartment called the scala tympani. That's the ideal outcome. And sometimes it doesn't always work, and you may get some breakthrough of the electrode array into another chamber within the cochlea called the scala vestibuli. That leads to more complications. So having done the operation, normally we would then do an X-ray within the first day after the person is recovering. And the idea behind this is really to confirm that it's in place, to confirm if the entire electrode array has gone inside the cochlea. It's not always possible to be sure of that during the surgery itself. And it can also be used to determine how deeply the cochlear implant's been put in, and that might help us with tuning or programming the implant, which is the area the audiologist needs to be concerned about. So I think the last thing that you need to be aware of is that cochlear implant outcomes are very positive and they make a huge difference to people's lives, but they're not without complications. No surgery is without its complications. So you need to be aware that there are a number of things which can go wrong. The rates are pretty low, but they are important. So they include things like scalp flap problems or infections around the site where the actual implant package sits. That's rare, but it can be a very serious complication because it may lead to extrusion or spontaneous removal of the device. A known complication is facial nerve paralysis or disturbance. It may be temporary, it may be permanent. It is very rare, but the facial nerve is in close proximity to all the hearing structures, and that's a really important consideration for the surgeon. A very common complication, but it's normally temporary, is balance disturbance. So people quite often find they get some temporary imbalance or dizziness. Normally this resolves fairly quickly, but it's important to know about it, and it's really important that the patient themselves knows about it in advance. The person may get non-auditory stimulation such as facial twitching after they receive the implant, although normally it's possible to solve this through tuning. And then another area which we wouldn't have considered a complication in the past, but I think we now should, is loss of residual hearing, because residual hearing or natural hearing should be preserved wherever possible when a cochlear implant is put in. So I want to say a little bit more about that. Meningitis, as I mentioned, is a very serious complication, again very rare, but there is a slightly increased risk of meningitis due to cochlear implant surgery. And obviously, poor performance, not doing well with the implant, can be considered a risk of surgery, although there are many factors which may determine if this happens. And finally, the device may fail. So you might need to go through the whole process again, explant the device, reimplant. I'll say a bit more about that before I finish. We should also think about short-term and long-term complications. So people can develop complications many years after they've had the implant, and we need to be aware of those risks. Okay, so I want to say a little bit about residual hearing. This is effectively a type of complication. So if a person has natural low-frequency hearing, the surgeon will now try very hard to spare that hearing to ensure that the person can get benefit from the natural low-frequency hearing that will complement or enhance the hearing they get through the cochlear implant. And that's because combining the acoustic amplification in low frequencies with cochlear implant electrical hearing in the mid and high frequencies is known to benefit people above and beyond purely electrical or cochlear implant stimulation. There are a number of benefits that you can get by preserving low frequency hearing and making sure you can use low frequency hearing. So it's worth really, I think, thinking about this as a complication of surgery. It is commonly the case that people will lose some residual hearing, and typically 15 to 20 decibels, but is increasingly seen as an unwanted complication that surgeons are trying to reduce the risk. So we know there are a number of factors which change the risk of losing residual hearing. One of these is how the surgeon approaches the surgery, how quickly they do it, how quickly they insert the cochlear implant itself, because the slower the insertion, the lower the risk of actually damaging the hearing mechanism. Also, using steroids, particularly topically around the site of the insertion, can benefit people in terms of reducing that risk of loss of residual hearing. Certain types of electrode may also be beneficial. And there are other factors as well. And in future, we may also have cochlear implants which dispense their own steroid treatment to, again, reduce the risk of loss of residual hearing and to maintain the cochlear structures. So finally, I want to say a little bit about device failures, because a child might be implanted at the age of 6 or 7 months and they might live 100 years. So we need to have some idea how long the device is going to last, how likely is it that they're going to need to have it replaced. Roughly speaking, there's a failure rate of about 1 to 2% per year. So that does mean a child will need probably a couple of reimplantations during their lifetime. Occasionally there will be a group of failures that come together due to a manufacturing issue. This happens every so often, but mostly the manufacturers avoid this. And there are a number of different causes. I'm just referring you to a work we did a couple of years ago where we looked at the pattern of failures across the whole world using Food and Drug Administration data. This really looked at everybody who'd been explanted across the whole world over 3 years. And we found there were a variety of causes. And what was really interesting was that the slight majority of them were classified as being due to the device itself, but a sizable minority of cases were due to medical failures. So that's things like bony growth, tissue growth, and inflammatory responses in the inner ear, which we don't necessarily fully understand. So it's generally a good news story, but you need to know about this. You need to know that there is a failure rate and there are a number of different causes of failures. So I just want to wrap up really and just state the obvious. A cochlear implant is a surgical device. It is inserted surgically. And it doesn't matter if you're an audiologist, if you're a therapist, or anybody else. If you're working with cochlear implant patients, you do need to understand the main surgical issues. It doesn't just apply to surgeons. In addition to that, you need to think about complications, adverse events. You need to be aware of them so you can advise people accordingly. And it's also really important to understand the medical aspects of assessment beyond and above just the purely hearing testing aspects of it. So thank you very much, and I hope you enjoy the rest of the course.